Now, you've heard already just a couple of times about the analytical framework that was used in making this investment case. Well, to take us through that in a little bit more detail, I'd like to introduce Timothy Hallett. He is the Professor of Global Health at Imperial College, and he's also the Chair of the Global Fund Modelling Guidance Group.
Thank you very much. It's really a privilege to be here and to give this talk on the investment case for the 8th replenishment of the Global Fund. I'm going to be focusing on the work we've done to understand the potential health impact that such a replenishment could contribute to. I'm representing here the Modelling Guidance Group of the Global Fund, which is a group composed of technical leads from each of their partners, experts in modelling, economics and epidemiology, and the actual disease modelling teams that did the modelling for the global plans in each disease area. So that's Avenir Health for HIV and TB, and Imperial College London for malaria. And let me confirm that, as usual, all of the impact modelling being done here is done using the very same models that global partners use and have endorsed. So what resources do we think are needed? So as you know, technical partners at UNAIDS, Stop TB Partnership and World Health Organization each produce plans that show what programs should be scaled up in each country in order to achieve the targets for control of these diseases by 2030 as enshrined in the SDGs 3.6. This creates an effective glide path for how these epidemics should be declining if those targets are to be reached. The plans, therefore, also show the cost of the programs that are being demanded. Summing up those costs for the period of 27 to 2029, which is the period when the money raised in this replenishment would mostly be spent, we get $146 billion. So how do the resources available stack up against this need? So firstly, we anticipate domestic resources totaling $69.7 billion. Now that's based on taking the average of 5 years of data on annual expenditure in each country for each disease, and then projecting it forward under the assumption that spending on these diseases will grow in line with all other aspects of government expenditure. The only exception to that is for TB in India, where a slightly more optimistic projection is used, given the strong political will demonstrated to combat TB. For other non-global fund external financing, well, we assume this will remain at the same level in real terms as the average in the period 2020-2022. Then, with a successful replenishment of the global fund of $18 billion, it all adds up to approximately 79% of resource needs being met. For context, the resource needs are $10.4 billion more than we foresaw for the period 2024-2026 at the 7th replenishment. But our projections suggest that this increased need will be met, actually more than met, by the growth in domestic resources. As a result, with an $18 billion replenishment, the overall proportion of needs that is being met will be about the same as last time, and the proportion being met by the Global Fund actually edges slightly down. So what impact can be achieved with these resources? So I'm going to show you a series of graphs that look a bit like this. So let me first orientate you to these axes. So the horizontal axis is showing time. Now we're currently in the period when the funding from the 7th replenishments are being used, which will come to an end at the end of 2026. And for this talk, I'm going to be focusing on the impact that could be achieved in the 3-year period after that, 2027 to 2029, when the funds from the 8th replenishment would mostly be being used. Now, the vertical axis on this graph is showing the mortality rate aggregated over all 3 diseases. To make it easy to read, we've normalized the scale so that we're at a value of 100 in the year 2020. The black line is showing the actual epidemiological data, what's really happened so far. The dotted purple line shows the trajectory if there was no scale-up of services at all for HIV, TB, malaria in 2024 or afterwards. So it's like the programs are frozen at the end of 2023. The yellow line shows the global plan glide path that takes us towards the targets that UNAIDS, Stop TB Partnership and WHO have set. Now we can see that we're already above that glide path. We're off course, and we do have catching up to do. The turquoise line with the associated uncertainty bounds shows that the impact that is potentially achievable with the totality of the resources predicted to be available, including, as I've said, the successful global fund replenishment of $18 billion and the other resources I've described, assuming that, one, the funding for programs is efficiently allocated to the most suitable programs in the places where they can have the greatest impact, two, and that the global funds are distributed across the diseases as per the agreed global disease split and to countries where it can have the greatest additive impact. Now the dots are showing the global fund impact targets set for 2028, of which there were low, intermediate and high variance. So, mortality. We're projecting that there could be 23 million lives saved between 2027 and 2029. That's compared to our standard comparator, which is essentially that there would be suddenly no programs at all. It's a reduction in the mortality rate by 64% across these three diseases in 2029 compared to 2023 levels. And we'll be going from 2.3 million deaths in 2023 to 920,000 deaths in 2029. It would meet the global fund impact targets and just about credibly reach those global plan trajectories. Turning to incidence, where it's the incidence of HIV infection or the incidence of TB and malaria cases, we're projecting that there could be 400 million infections or cases averted between 2027 and 2029, and that's compared to our standard comparator, which is effectively there'll be no more scale-up of services from 2023 levels. That's a reduction in the incidence rate by 54% across all those diseases in 2029 compared to 2023, taking us from 271 million infections or cases in 2023 to 119 million in 2029. It's also meeting the Global Fund impact target and substantially closes the gap as much as possible on the global plan trajectories. So I'm now going to talk about the results in a bit more detail for each disease. So firstly, HIV. So under our assumptions, including the $18 billion replenishment and the other funding that I've mentioned, we project that there is indeed every chance of the UNAIDS targets for incidence and deaths being met. From 2023 to 2029, new infections would be reduced by another 66%. AIDS deaths would be reduced by another 59%. HIV incidence rate among adolescent girls and young women in the most affected countries would be reduced by another 51%. And by 2029, there would be 28.9 million persons on treatment for a 90% coverage level. For TB, we can see that we would be set on a trajectory to get close to global plan goals that have been set for 2035, with the acceleration coming later as more and more technologies come online and their effects accumulate. From 2023 to 2029, we project TB cases coming down by 26%, deaths down by 57%, and in total, between 2024 and 2029, 46.8 million persons being treated with first-line therapies and 1.1 million persons being treated with second-line therapies, and a 95% coverage by 2029. And for malaria, following a stalling of impact, as you've heard already, we can see that there is potential for enormous progress to be made, actually, towards the global plan targets of both incidence and disease and deaths in the coming years. So between 2023 and 2029, we think that it could be that malaria cases come down by as much as 57% and malaria deaths by as much as 65%, such that in 2029, there would be 59% of persons sleeping under a long-lasting insecticide-treated net in sub-Saharan Africa, compared to 49% in 2023. And between 2027 and 2029, there would be 263 million cases treated. Now, to give us even more of an idea of the huge value of this health gain, we've considered the monetary value that persons affected would themselves place on the reduced risk of becoming ill with these diseases. So the impact on health in each disease that I've described, specifically the difference between the investment case projection and the no scale-up scenario, would have a monetized intrinsic value 19 times the size of the resources that are being used. That's a 19-to-1 return on investment. So for the $18 billion global fund replenishment, that's $323 billion of value being generated between 2027 and 2029. Of course, you might be interested specifically in the direct effect on the economy of these changes in health. We can estimate the additional productive work that persons can do thanks to the increases in their health. And we estimate that would be $60 billion in that same period, and that's a 3.5-to-1 return for direct economic benefits. I will focus on two further quantifications of these health benefits that I think help us understand how this impact fits within the wider context. So first, there's the concept of inequality in life expectancy. So as you know, these three diseases are some of the biggest sources of mortality, and they contribute to there being a much lower life expectancy of persons in lower income settings than higher income settings. We call this the global inequality in life expectancy. Impact on investments in HIV, TB, and malaria have already reduced this inequality in life expectancy. For instance, in 15 sub-Saharan African countries, it's increased by 6.2 years. And the health impacts I'm describing here would build on that even more and reduce this inequality by another 7% between 2023 and 2029. And these enormous increases in life expectancy and the leveling of this between the countries will have a transformatory impact on societies. Furthermore, we can think about how these health gains help primary health care. Reducing the burden of these three diseases by so much will also avoid the need for stretched and fragile healthcare systems to provide healthcare for those persons. If there's fewer cases of HIV, TB, and malaria, then the healthcare system can use its valuable resources helping other patients. We've quantified that the health impact I've described would, in the period 2024 to 2029, free up 1.6 billion hospital days that would otherwise have been needed for activities related to the three diseases, and 3.1 billion outpatient visits. This would reduce the effective cost of providing primary health care by $42 billion in that period. And you can see in this graph that 77% of these cost savings will be in sub-Saharan Africa, exactly where they are needed most, and where the freed up resources will have the greatest impact for other patients. These major investments in the Global Fund will also help strengthen healthcare systems, and so also build resilience and pandemic preparedness, specifically through the contributions to human resources for health, including community healthcare workers, laboratories and diagnostics, disease surveillance, supply chains, oxygen and respiratory care, digital health and information systems, and so on. And we can illustrate how this actually works in the case of Malawi, where new modeling by the Thanzila Onze program estimates that there would be a 35% greater reduction in HIV, TB, and malaria if the expansion of services for those diseases is combined with investments in more healthcare workers and stronger medicine supply chains compared to if it were not. And that the total impact of that program, scaling up HIV, TB, malaria control, and strengthening healthcare systems, would have substantial health benefits beyond HIV, TB, and malaria, perhaps about half as much again in the period between 2023 and 2029, due to the improved care that would become possible for other conditions, including childhood diseases, maternal outcomes, and many more causes. So look, that's a lot of bidirectional synergy. Stronger healthcare systems benefit other diseases and accelerate progress against HIV, TB, and malaria. And the progress against HIV, TB, and malaria itself helps the healthcare system by freeing up resources. So let me close by repeating what I think are the headline results for this work. Securing $18 billion for the Global Fund would contribute to 23 million lives saved between 2027 and 2029, and 400 million infections or cases averted in that same period, getting us as close as possible to those global planned ambitions for disease control and elimination, all whilst generating $19 of value for every $1 invested. It's a truly compelling case. Thank you very much.
Professor Hallett, thank you so very much, and indeed, of course, to all of our experts today.